Bueno, pues vamos a seguir.
Ole. We are now going to move forward, and here we go. Doctora Mariño, you have the floor. Very well. Thank you very much. Before we move forward, thank you very much for the invitation. Thank you, AIDA. Thank you, the association. Thank you, Carmen, for hosting us and for inviting me. Marina and I share one thought, and that is that we're more than happy and honored to be here. We hope this to be useful. What I wanted to show you is how do we do the follow-up? How do we follow up Wilson disease, not diagnosing or screening, but also following up those patients that have a firm diagnosis of WD. As you are probably all fully aware, it is quite heterogeneous disease. We have many potential possible symptoms that can appear throughout the time. And because it is a genetic disease, it will depend on the progression of time for some symptoms to appear rather than others. This was published last year. It's something that I really like because we can see here how dynamic the disease is and how important early diagnosis is. It will depend, of course, on when it was diagnosed, whether early or not, advanced or not disease. So we move forward with one type of treatment or therapy rather than another one. What are our objectives when we follow up a patient presented with Wilson's disease from the medical point of view? Well, what we want to do first is to make sure that we control the heavy deposits of copper. We do that on very early onset, those that are detected via familiar studies where we don't have damage. In most of the cases, what we are doing is treating. We want to avoid progression of damage, and if we can, reverse the damage, those that are presented with tisular damage because of the copper deposits. Unfortunately, in some of the cases, what we do is to rescue those patients that have such a severe, important damage where medical treatment is not going to work. For example, in those cases where we have to be very aggressive and even arrive at the liver transplant. This clearly highlights how important it is to have an early diagnosis. So the earlier we diagnose, the better we'll be off. Once we have diagnosed, do we have to follow up? Yes. Not only do we need a diagnosis, but ulteriorly, we need to control the presentation and manifestation of the disease. We need to ensure the safety of the treatments. We need to be vigilant of the treatment efficacy. We need to prevent the disease progression, make sure that we are efficient. We need to have efficacy in the treatment clinically and analytically. The progression of the disease has to be prevented. We need to make sure that we do not have any other ancillary issues that could be related to the disease and also be able to avoid progression because we could be doing it wrong there. We need to do health awareness, health education, answer your doubts, and provide counseling for the family and carers and coaching. Obviously improve the adherence to treatment. How do we do this in our clinical practice? We have different strategies that are pretty much divided into these 4 categories of clinical tools. Clinical aspects, what do you see? What do you have in front of you? We could do a physical examination, we do interview, we assess, we do the exploration. Then we have the biomarkers, whether urine or blood. We have complementary tests, which we will talk about it, and then multidisciplinary teams or holistic approach. If we now concentrate on the clinical aspects, unfortunately, but this is part of all the hepatic diseases. Liver clearly does not show patients that are presented with an isolated hepatic. You're not going to feel pain. You're not going to feel itching or anything unless you have a very advanced hepatic, for example, cirrhosis or failure of the hepatic function. But unfortunately, fortunately for us, that's the minority of it. So we probably are not going to see a clinical improvement of those that have, but with patients that have an advanced status of the disease, we will have that. But if we have fasciitis, or here we have a discompensated cirrhosis, after treatment we see that it disappears. Ascites, or somebody that is presented with jaundice, that yellowish coloring of the skin and the eye. But this is not something that we normally see. Neurologists have a very good scale that we have. Dr. Obadia has mentioned it, which is the UWDRS, the Unified Wilson Disease Rating Scale, and that allows you to see an improvement. The neurological symptomatology is easily, quote unquote, easily scored, and through time and treatment, these scales improve, and they are quantifiable from the baseline, and then we can do a follow-up in the coming months or not. What can we say about the biomarkers? What are useful biomarkers? Some of them are, again, blood or plasma, some in the urine. One is inflammation of the liver and the function of the liver, which is different, inflammation and function, liver function. So we have the ASAT, ALAT, when we see transaminase reaching high levels, it's an inflammation of the liver. If this improves with time, you're being efficient. We see that about 6 months after it has been treated, after therapy starts. The function of the liver is clearing toxic in nature, and we see that about albumin, BT or TPs. Some patients could be presented with hemolytic anemia. These are red cells that are being destroyed because of the toxic membrane, outer membrane of the copper. If that disappears, we could then infer that we're being okay. And the ceruloplasmin, it's not going to change throughout time, but the function of the liver is going to improve, and you're going to have more ceruloplasmin. What can we check for in blood? The famous exchangeable copper, and we try to see the NCC, those that are presented with the one that is non-bound to the ceruloplasmin. Classically, that was calculated with a mathematical formula. And for all mathematical formulas, we need to understand that there are limitations because it depends on the ceruloplasmin. And we could have 20% of cases that were not easily detected. Oops, sorry, here we go. But right here, we are now measuring that ratio, okay, that is non-bound. We've talked about this in several occasions, the exchangeable and the ratio of the REC, the ratio of exchangeable copper, is this new marker. It has been used in France for a while. Now we use it in Spain. It's not perfect, but we cannot and should not use just one single biomarker. We rather should have an array of biomarkers to be used, and throughout time during the follow-up, we're going to be limited at very few trials or studies. I believe there's only one of Eduardo's et al., Eduardo's group in Lyon, in France, how this REC changes. These were 36 children that have been diagnosed with WD over time, and how through the years, the start of the years, decrease. But that has not been assessed nor evaluated extensively. As a matter of fact, recent studies that were presented by Dr. Peter Ott 2 weeks ago in the American meeting, we see that during the follow-up, this exchangeable copper has a variability even in the same patient. So we need more experience in order to know how we're going to use it. In our center, we have been using it for the last couple of years, and this is pretty good. This is just to show you this variability that we have in our real patients, and despite the range of normality that was established between 41 and 71, a high percentage of patients that you see in the patients are below, if you see the plotted map, are below that threshold or that range normality. We've done a joint study with Dr. Berenguer, and it looks pretty much clear that we need to follow around these lines because we still have no clear position of where we should have our patients with these patients that are positive for this biomarker. And we go to this one. If we look at urinary copper, it's a pain, a real pain to collect in 24 hours, but we still use it because we understand that there's an excretion of copper via urine and not feces. So we need to know where we are. Are we diagnosing or are we in the following up stage? And we need to know what treatment is being, if you have a zinc treatment where we're trying to, or those that are with theta or with DP. So we need to have international guidelines in order to keep the patients within the range that is appropriate and the stage of the disease that we are at. This is a real example of a patient from my clinic. You can see here, these were the transaminase levels, and as she moved forward, they pretty much reach normal. This will be ideal, but it's not always that easy. In the right chart, the right-hand chart, this is urinary copper, a patient that was over. This is actually why it triggered a diagnosis. We started with chelating agents and excretion via urine, and as we start washing out this patient, we maintain this throughout time. This is what we normally see, and that's why it's so important, the 24-hour urinary copper test. What else do we have? We have complementary tests, just like the title states. They complement, they provide additional information regarding the status of the disease, regarding with what convinces here, which is the liver. It's the liver elastography. We measure the scarring that we have, the LSM. Probably many of you have gone through this. It just hits the wall of the abdomen, and that is reflected, and the speed at which that wave of heating, okay, it's related to the rigidity. And the more scarring, the more rigid will be. The scarring will be part of the damage because it is a non-invasive test. We can repeat it as many times as we want, depending, of course, of the availability we have. But this clearly shows where we are and where we could be. We have very little data of elastography, of liver elastography with Wilson disease. Why? Because it's a rare disease. As many, or if not all the rare diseases, we have not much documentation. But this from the Vienna and the German groups, they were assessing the trend of the LSM in patients that had recently been diagnosed with WD, especially in the upper right chart. Those patients that are not presented with cirrhosis, we clearly see that we do not have thresholds or cutoff points, but it really helps individual patients. If a patient has a score of 8 and then you see 4, 5, 4, 3, then obviously it's okay. But if you see 8 and then 12 and then 14 and then 20, then you better say, oops, something is happening. We might not know what's going on, but definitely we see that we have more rigidity. Something else we have is echography, totally different from elastography. Here we're looking at the change in shape of the liver, if it's cirrhosis, if there are abnormal changes, if there's an enlargement of the spleen, if there's a lesion within the liver. As treatment goes by and spans, we could see those patients that we should expect to find the liver going towards normal. Those patients that were presented with cirrhosis from the start, you should do the test, the echo, every 6 months, just to make sure that there are no tumor, no masses in the liver. What other complementary we have? The biopsy. The biopsy, it is invasive. Obviously, there are some risks associated. Biopsies nowadays are pretty safe, but we cannot discard that in a very small percentage of patients could have a complication or be presented with pain. So we cannot just keep on repeating it. We cannot do one every year, but if we talk about the follow-up, not for diagnosis, but for follow-up, could provide us with additional information that could be useful in some cases, because we could then know what is happening unless we are invasive. It could tell us if there's another comorbidity. It could tell us if there's inflammation. It could tell us if there's fat deposits or plaques. So sometimes it could be useful and it could help us. The last part is how valuable multidisciplinary approaches are, especially for rare diseases. Rare diseases have this component, and it's very hard to have experience, a specific experience. So it is important that all patients, are treated and are clinically supported by those centers where we have many different areas of a specialty and we can work together. Not only that, but these centers, most of the times we do have colleagues that are even important. We're talking about hepatologists, neurologists, pediatricians, geneticians, general pharmacy, biochem, image and radiology. If we did not have help with biochem department, we would not have been able in my center to now do the exchangeable ratio. And of course, we need to have clinical research and translational research, because if we all work jointly, then we can move forward. Those of you that have visited me in the center, you signed three or four forms, because we need to move forward, and we're going to do a battery of tests, and that is part of how we work. And we also have to underscore how important nursing and pharmacy is. Sometimes we physicians are in a different brain frequency. We're at full speed, full throttle, but rather the nursing and the pharmacy can help us with medication adherence. Why is therapy adherence so important? We know that patients that had no symptoms when they were diagnosed, along with patients that have, the results are going to be very different. Adherence versus non-adherence. You can see it in the left side signs. Those patients that are not taking the medication vis-a-vis those that are taking medication throughout time. Something else we need to remember is that follow-up is dynamic throughout time, because our work in your clinical visits is not just asking, how are you? We need to anticipate. We need to understand that there are going to be changes, to detect changes, both in lab results and physically. And we need to say, is the drug therapy not correct? Should I increase dosage? Is it a problem of adherence? Are there different studies that have been published that those that have to do chronic therapies, the rate of non-adherence could raise up to 50%. And it is logical. And I'm not just talking about Wilson's disease. Sometimes it's hard, and it's understandable, but we also need to anticipate that can happen. And last but not least, we need to see if there are comorbidities. Is the patient now presented DB, or is it drinking alcohol, or are you taking medication that was toxic to patients from the Wilson's disease? Can also be sick with something else. So the proposal that we have not just for my center, but similar to Lyon or Paris or Denmark, is to follow up the patient, and to follow up the patient that has to be adapted to the availability of each of its centers, and also adapted to the patient. But what we do is a blood battery of tests. Then we do urine tests every 6 months, more frequent if we see there's a change in drug therapy or treatment. We do the liver elastography. I try to do it every year, and if not, at least between 1 and 3 years. Then liver ultrasound. Maybe not that relevant for those that have a sign of cirrhosis. If not, you will do it every 6 months. And those patients that have in the multidisciplinary unit are assessed by psychiatrists and or neurologists. And last but not least, we need to really underscore, to guarantee, to ensure adherence. And that's why I have held Ana Miralpesc, Montse Rodriguez, respectively the head nurse of the unit and director of the general pharmacy, and takeaway messages after diagnosis and start of treatment. We need to perform follow-up. It is essential because we will assure control of the disease. Obviously, the sign and symptoms will be evaluated, but we need to make sure that what we had detected is going to be reverted, and we assess blood and urine biomarkers, and they're going to be complementary, and sometimes it could even reach biopsies. And patient follow-up in multidisciplinary units favors this holistic follow-up, more complete follow-up of the patients, and that, of course, provides us with a better result. And thank you very much for your attention.